Hi there, this will be the first of two videos on internuclear ophthalmoplegia. In this video, we will use the analogy shown to explain how the horizontal gaze pathway works and how it can get damaged to cause an internuclear ophthalmoplegia, or INO for short. The second video titled INO related syndromes will build on this analogy and see how horizontal gaze is affected in lateral pontine lesions as well as rarer INO syndromes. These include the 1.5 syndrome, half and half syndrome, and the posterior INO of Lutz. When we look left or right, the eyes need to move together in the same direction and speed. This is known as conjugate eye movement. If you want to look to your left eye needs to abduct, and simultaneously your right eye needs to adduct, both at the same speed so that you don't develop double vision. Looking horizontally left and right uses the lateral rectus of one eye and the medial rectus of the other. As both these muscles work together to look in a certain direction, we can say these muscles are yoked pairs. We have yoked eye muscle pairs for all 6 cardinal positions of gaze. We'll now go through the analogy shown to help you to better understand the mechanism of horizontal conjugate gaze. The perspective is that you are looking at a patient's eyes on the screen. When you first decide you want to look left or right, a particular part of the opposite cerebral cortex is activated. As an example, if you want to make a fast saccadic movement of the eyes to the left, your right frontal eye field, which is found in the right frontal lobe, is first activated. Of note, the eye fields are not shown in this analogy. Regardless of the type of horizontal eye movement, the result is that the eye fields send impulses to the opposite part of the brainstem, to an area known as the Paramedian Pontine Reticular Formation, or PPRF for short. The PPRF is a collection of nuclei found in the pons and is located next to the Abducens nucleus. The PPRF is often referred to as a horizontal gaze center for conjugate eye movement. It is represented by the blue handles as shown. Through connecting interneurons, the PPRF gives innervation to the Abducens nucleus, which has 2 different types of neurons. There are the Abducens motor neurons, which make up 70% of the nucleus, and the Abducens interneurons, which make up the resulting 30%. The arrows pointing to the Abducens motor neurons of the Abducens nucleus, represented by the green rectangle. As the name suggests, this gives motor output via the Abducens nerve. The Abducens nerve is represented by the green rope, which supplies the lateral rectus muscle. This is shown by the green rope after the pulley to help abduct the eye. The PPRF also gives innervation to the Abducens interneurons of the Abducens nucleus. This is shown by the other green rectangle, which connects the PPRF to a highly myelinated tract known as the medial longitudinal fasciculus. In reality, the Abducens interneurons cross the midline to become part of the medial longitudinal fasciculus, but for analogy purposes, this has been made shorter as shown. The analogy shows the Abducens motor neurons and interneurons as being physically separate, but actually they are found together in the same Abducens nucleus. This separation has been done to better explain a particular INO-related syndrome that will be covered in the subsequent video. The medial longitudinal fasciculus, or MLF for short, is a densely myelinated white matter tract, represented by the thick grey rope. The MLFs are located near the midline of the brainstem, where they cross each other. Among other functions, the MLF serves to connect the ipsilateral Abducens nucleus with the contralateral medial rectus subnucleus. The MLF is named according to which side it goes to, with a grey rope beginning from the right PPRF and going to the left eye is the left MLF. The left-sided grey rope going towards the right eye is the right MLF. The role of the MLF in helping with conjugate eye movement cannot be overstated, which is demonstrated by the fact it is found in all vertebrates, as well as being the first tract to myelinate in human beings. The oculomotor nucleus is found in the upper midbrain and innervates many extraocular muscles. In reality, the oculomotor nucleus is a combination of multiple subnuclei which supply its associated muscle. The medial rectus subnucleus or the oculomotor nucleus is shown by the red rectangle. This medial rectus subnucleus gives off motor neurons that are part of the oculomotor nerve that go to the medial rectus. The medial rectus muscle is illustrated by the red rope after the pulley to help adduct the eye. The pulleys shown by the arrows are only illustrated to help better explain the analogy. This is also true of the ropes representing the eye muscles that are attached to the pupil rather than the globe of the eye. The red dot represents the target that the patient is being asked to follow with their head kept still. To pick up subtle horizontal gaze abnormalities, the patient is asked to look in one direction laterally, such as the right, and then suddenly to the left by showing another target. This makes the patient create a large horizontal saccadic eye movement. This can help detect subtle pathological slowing of eye movement, which can help localize the problem. The animation will slow down the saccadic eye movements to make it easier to follow how the various components work together. If the patient is asked to quickly look at the red target on the right, the first step in this process is that the left frontal eye fields send impulses to activate the right PPRF. This leads to two simultaneous actions. The first action is the right PPRF tells the right abducens nucleus motor neurons to fire, which sends impulses via the right abducens nerve to the right lateral rectus, which abducts the right eye. At the same time, the right PPRF tells the right abducens nucleus interneurons to fire, which activates the left MLF going to the left medial rectus subnucleus. This gives off motor neurons that are part of the left oculomotor nerve and go to left medial rectus to help adduct the left eye. The analogy represents these two simultaneous actions of the white blue handle representing the right PPRF being pulled, which pulls on the green rope representing the abducens nerve to pull the right eye towards it to the right. At the same time, the white blue handle is connected to the thick grey rope representing the left MLF and the red rope representing the left oculomotor nerve, which pulls the left eye towards the right. When asked to look to the left, the same actions happen in the mirror image. In short, the sign that the PPRF is activated is the side that gaze will be directed to. By imagining the pull of the PPRF bringing the eyes towards it, you can use the analogy to work out what happens when a lesion affects one or more of these structures. The vast majority of lesions tend to be strokes or demyelinating lesions such as multiple sclerosis. Uncommonly, infections, tumours and head trauma are also implicated. As the MLF is heavily myelinated, it is a common target for demyelinating diseases. If the MLF is partially damaged, as shown by the left MLF becoming thinner and wavy, impulses can still travel through it, but they are significantly slowed down. When looking to the right eye abducts normally, as the chain from the right PPRF to the right lateral rectus is unaffected. As the left MLF is partially damaged, this slows down the signal from the right PPRF to the left medial rectus. This leads to the left eye adducting slower compared to the abducting right eye. This slowing of the adducting eye is known as an adduction lag, which is commonly seen with partial MLF lesions. When the patient looks to the left, their right MLF is working fine, as shown by the normal thick grey rope, and there's no abnormal eye movement seen. If a patient has partial right MLF damage, the same thing happens in the mirror image to the previous case. Looking right is normal as the left MLF is intact. When looking left, the left eye abducts normally, but there is an adduction lag of the right eye. By representing the partially damaged MLF as a thinner, longer and wavy grey rope, this illustrates the time delay from when the PPRF is pulled and that pull action reaching the red rope on the opposite side. Watching the movements again, in real life the best way to appreciate the adduction lag is to not look directly in each eye, but rather between the eyes. By doing this, you engage your peripheral vision, which is much better at detecting changes in motion. If the right MLF is completely damaged, as shown by the white grey rope breaking off, there will be no connection between the left PPRF and the right medial rectus. Looking right is fine as the left MLF is working normally. When looking left, the left PPRF cannot communicate to the right medial rectus to adduct the right eye, and so it stays in place. The left eye can abduct normally. If the patient is asked to keep looking at the target, the abducting eye may show a horizontal dissociating abducting nystagmus. It is called dissociated as you can see it in one eye only. The nystagmus occurs 90% of the time. It is thought to be due to an unsuccessful compensatory mechanism where the PPRF tries to increase the firing rate to the medial rectus to adduct the eye. However, this does not work as the damaged MLF breaks the connection. In this process, however, the PPRF indirectly causes the abducens nucleus motor neurons to overfire, causing horizontal dissociating abducting nystagmus. This is represented in the analogy with the left blue handle being repeatedly pulled in an unsuccessful attempt to pull the right eye, but at the same time, this repeated pulling acts on the left green rope to create the dissociating abducting nystagmus. If the left MLF is damaged, this becomes a mirror image of the previous case. As the left grey rope is gone, when looking to the right eye abducts normally, but the left eye cannot adduct as there is no grey rope connecting the white blue handle to the left red rectangle. Keeping the patient's gaze to the right, the dissociating abducting nystagmus is seen. Looking left, both eyes move normally as there is no damage to the right MLF. Quickly reviewing terminology, the prefix internucleus given because damage to the MLF either slows or stops communication between the ipsilateral 6th and contralateral 3rd cranial nerve nuclei. Depending on the degree of MLF damage, either the suffix ophthalmoparesis or ophthalmoplegia is used. Ophthalmoparesis is when there is partial MLF damage, and so some of its axons can still work. This causes the adducting eye to move slowly or incompletely, causing the adduction lag. Ophthalmoplegia is when there is complete MLF damage with no axons working. This means there is no adducting eye movement seen on the side of the MLF lesion. If we combine a left and right INO, we get a bilateral INO, or BINO for short. This is almost pathognomonic for multiple sclerosis, where a single midline lesion can damage both MLFs. The outcome is the same as that seen in a unilateral INO, where on looking either left or right, the contralateral eye cannot adduct as the MLF going to that side is damaged. The mechanism of the dissociated abducting nystagmus is the same as in a unilateral INO. 10% of the time, an abduction nystagmus is not seen. This means if someone has an INO or BINO, the horizontal eye movement abnormality needs to be distinguished from other conditions that can mimic an INO termed Pseudo-INO. Conditions that can cause Pseudo-INO are myasthenia gravis, partial oculomotor nerve palsy, or isolated medial rectus palsy. These conditions do not damage the MLF, whereas a real INO does. A simple way to check if the MLF is damaged is to ask the patient to focus on a target being brought towards them. This tests convergence, which is the ability for both eyes to adduct to keep the target fixed on the fovea as it is brought closer. This is shown in the analogy with both red rectangles depicting the medial rectus subnuclei being pulled to converge the eyes. The convergence pathways and medial rectus subnuclei are found in the upper midbrain. Convergence does not use the MLFs, and so it is usually intact when an INO or BINO is caused by lower midbrain or Pontine MLF lesion, which is where the majority of MLF lesions occur. Conditions that cause Pseudo-INO affect the medial rectus subnuclei, muscle, or the junction between them without affecting the MLF, which leads to impaired convergence. In summary, the ability to look left or right relies on a final common pathway where the ipsilateral PPRF abducts the ipsilateral eye and via the MLF adducts the contralateral eye. The long anatomy of the MLF makes it prone to damage, which, if damaged, causes an adduction problem ipsilateral to the MLF damage. So, if the patient looks right and the left eye has an adduction lag, this is a left internuclear ophthalmoparesis due to incomplete left MLF damage. If another patient looks left and the right eye is not adducting with a dissociated left eye abducting nystagmus, this is a right INO due to complete right MLF damage. As an aside, the eye movements that occur in INO with associated nystagmus are rarely seen in non-MLF lesions, making it arguably the most discrete localizing sign in medicine. In the next video, we will build further on this analogy to understand other disorders of horizontal gaze. These include Wabino, 1.5 syndrome, half and half syndrome, and the posterior INO of Lutz.